A patient wakes up in a hospital bed. They see the fluorescent lights on the ceiling. They hear the monitors beeping and nurses speaking. They try to sit up, but their limbs do not move. They try to call out, but their vocal cords do not respond. From the perspective of the medical staff standing at the foot of the bed, the patient's body provides zero outward signals of life. They appear completely unresponsive. The mind processes every conversation and physical sensation in the room, but the skeletal muscles cannot twitch to signal awareness or distress. This exact clinical presentation is a documented, localizable neurological condition known as locked-in syndrome, or LIS. The diagnosis of LIS hinges on a specific physical triad. The first two components are quadriplegia, which is the complete paralysis of all four limbs, and anarthria, the total inability to articulate speech. However, unlike brain death or a deep coma, the cerebral cortex, the area responsible for high-level thought and cognition, remains perfectly intact. The patient is completely conscious. The singular physical loophole in this paralysis is the preservation of oculomotor pathways. The muscles controlling vertical eye movements and blinking continue to function. Patients must rely entirely on these preserved vertical movements to interact with their environment, frequently establishing communication by blinking once for yes and twice for no. LIS presents a precise dichotomy, a fully active mind severed from a completely paralyzed body. To understand how this isolation occurs, we must trace the anatomical disconnect. The brainstem acts as the central relay station of the central nervous system. It is the master cable connecting the computing power of the cerebrum to the mechanical output of the spinal cord. This anatomical diagram illustrates the three vertical segments of this relay station. From top to bottom, they are the midbrain, the pons, and the medulla. Looking closely at this diagram of descending pathways, the corticospinal tract is visible in blue. This pathway carries the electrical commands for bodily movement from the brain down to the spine. Traveling parallel to it is the corticobulbar tract, which delivers the motor commands for facial expressions and speech. Notice how these motor highways converge into a tight, dense bundle as they pass through the midlevels. Running in the opposite direction, firing upwards toward the cortex, is the reticular activating system, or RAS. The RAS is the network of neurons responsible for keeping the brain awake and conscious. Massive amounts of downward motor data and upward consciousness data run simultaneously through the microscopic space of the pons. Because of this proximity, the exact millimeter where an injury occurs determines the clinical outcome. This illustration shows a cross-section of the pons, dividing its anatomy into two distinct zones, the ventral basis at the front and the dorsal tegmentum at the back. Locked-in syndrome is the direct mechanical result of a destructive lesion localized exclusively in the ventral part of the pons, marked here by the red circle and cross. This specific ventral destruction completely severs both the corticospinal and corticonuclear tracts. The physical cables carrying motor commands are cut, resulting in instant total paralysis of the body and face. Yet, looking at the dorsal region at the top of the diagram, the reticular formation and the oculomotor pathways sit safely outside the zone of destruction. The ventral damage cuts the physical motor cables, while the dorsal sparing leaves the consciousness engine running. This precise anatomical splitting guarantees the patient remains awake while losing all ability to move. The most frequent physiological event that destroys the ventral pons is a massive thrombosis, a blood clot, blocking the basilar artery. This MRI scan shows the radiological footprint of this event. The lack of blood flow from the basilar clot creates a localized stroke directly in the center of the brainstem. Secondary causes can also generate lesions in this area. These include severe brainstem trauma, aggressive tumors, or central pontine myelinolysis, a condition where the protective myelin sheath around nerve cells is rapidly destroyed. The physical presentation varies depending on the exact edges of the lesion. In classic LIS, vertical eye blinking is the only residual movement that survives the paralysis. In incomplete LIS, tiny, inconsistent flickers of voluntary physical movement remain. Total LIS sits at the furthest end of the spectrum, where the paralysis extends to even the oculomotor pathways, eliminating all eye movements. Total LIS removes the patient's final mechanism for signaling the outside world. Without eye movement, the patient becomes physically indistinguishable from someone in a coma. When emergency room physicians evaluate a completely immobile, silent patient, they face a specific diagnostic challenge, proving the presence of an active mind without physical feedback. They must differentiate LIS from its closest visual mimics. A comatose patient is entirely unconscious with no movement. A vegetative state involves no awareness, displaying only basic reflexes. LIS patients are fully conscious with no movement. The first investigatory step is a brain MRI. This imaging confirms the anatomical presence of a pontine lesion and rules out widespread damage to the cerebral cortex. The definitive diagnostic tool is the electroencephalogram, or EEG. The EEG utilizes sensors placed on the scalp to measure the electrical activity and waveform patterns of the cortex. This is an EEG recording from an LIS patient. It shows completely normal, complex wave patterns. These dense electrical signals prove high-level cognitive function is occurring, despite the absolute lack of physical response. Misdiagnosing an LIS patient as vegetative consigns a conscious person to isolation. The EEG provides the data required to prove the patient is actively processing their environment. The acute emergency protocol focuses on identifying the stroke window immediately. Medical teams utilize thrombolysis, administering drugs to dissolve the basilar clot before tissue death in the pons becomes permanent. Patients who survive the acute phase transition to chronic supportive care. They rely entirely on mechanical ventilators for respiration and enteral feeding tubes for nutritional support. The highest risk of mortality during this phase stems from the secondary complications of total immobility. Medical teams must rigorously prevent severe respiratory infections and bed sores. Modern rehabilitation leverages the intact oculomotor pathways. To review the high-yield diagnostic facts, the definitive anatomical site of the destructive lesion is exclusively the ventral pons. The most common pathological cause is a basilar artery thrombosis. The defining clinical presentation is complete quadriplegia paired with entirely preserved consciousness. Locked-in syndrome tests the limits of clinical deduction. It isolates a fully functional human mind behind an immobile exterior, requiring precise medical science to recognize the signals trapped inside.